multimodality, trimodality approach. So we set out to really see, was radiation required in this cohort of patients? And the answer is no, that basis. And then we also set out to determine through using strict radiation quality assurance, strict definitions of operative complications, was preoperative chemoradiation delivered in that quality controlled context and associated with increased postoperative mortality and morbidity, and it was not. So the trial showed those findings. The oncological findings were in the context of poor pathological proxies of response that you would expect to impact on survival, but did not impact on overall survival and did not impact on disease-free survival. So the trial has moved things on from cross-trial and MAGIC trials, which were done at different kind of time periods and really addressed those two issues. But then very quickly after the trial was published, ESOPAC data has been presented, which would indicate that direct comparison of FLOT versus cross shows superiority for cross. We must see the full data, the full paper, to sign off on that. But in fact, many people have probably changed their practice or reconsidered their practice if they use trimodality therapy. And so we're in that context, we're in that mix. Final point I'd make is I would love to be able to share our Neo-AEGIS data and combine it with the ESOPAC data to get more powerful interpretation of all the data, in particular the differences between the chemotherapy arms, MAGIC and FLOT, and also cross in one trial versus the other trial when we combine them both. So we've learned a lot, but the field is moving very, very quick. Lots of new trials out there will be presented and published over the next couple of years that will perhaps shift the paradigm even more. Two challenges, really. The one was when we started the trial and designed the trial in 2013, it was best of day, perioperative chemotherapy, which was the MAGIC modification of the MAGIC regimen, versus the newly released high-impact cross regimen. But what nobody could have foreseen, really, was the outcome of the FLOT4 trial, the German trial of gastric and GE junction adenocarcinoma, which started after that and was published in 2019, but presented in 2018. And that showed such a benefit for FLOT versus MAGIC that we immediately had to adjust our sites to convert from a superiority design to a non-inferiority design. And that was the first challenge. But the questions didn't remain. Was radiation therapy essential? And it's not. And did it cause greater operative harm? And it did not. But it was a big surprise and it was a real challenge and a lot of statistical input with it. The second one, quite simply, was the pandemic. There's actually no control over that. But I think post-FLOT anyway, the recruitment to the trial was struggling a little bit. So post the FLOT4 trial. But once the pandemic started, it completely stopped. So at that point, because the survival curves from the first futility analysis, the second futility analysis were literally identical for perioperative chemotherapy and trimodality therapy, then the right thing to do was to call the trial at that point, that it was unlikely to complete and unlikely for any differences to emerge. I think every trial that's done leaves a lot of questions. It can make some answers, but there's still a lot of questions, and no trial has been powered on, just node positive cancer or earlier stage cancers like T2N0 or just biologically different cancers like poorly cohesive. So you can only make a rough interpretation of Neo-AEGIS, ESOPAC, any of the trials with respect to those groups of patients that we see every week in our multidisciplinary conversations, and also patient factors like age. Not as very difficult in the elderly, for example. Comorbidities, only fit patients are included in trials. There's so much we don't know, and trials almost need to be considered on that are unique to specific cohorts, or else we'll struggle with that sort of interpretation of trials that aren't predominantly including those patients. And then, secondly, obviously, we must begin to study biomarkers as best we can. Everybody has an optimistic present that the future will be wonderful and we'll be able to do patient-specific, person-specific treatments. But I believe it when I see it. It's a highly heterogeneous, very, very difficult cancer, esophageal cancer. And so we could be a long time waiting for major breakthroughs in that, in the neoadjuvant setting, but one hopes. But certainly circulating tumor DNA, microsatellite instability, HER2/neu, obviously, some things that are out there, PD-L1, we should be doing those routinely and trying to learn as much from the everyday and patterns of response and so on about that, as well as novel clinical trials that hopefully will continue to improve the outlook of a very dismal, difficult to cure cancer.